Steve and the organizing committee, thank you very much for inviting me again. I had a wonderful experience last year, and again, as I was telling you, this year seems to be on par to beating the last year's experience. And especially a great honor to talk with Dr. and Professor Andy Pearson and Dr. Chung in audience, whose work I kind of grew up admiring and learning from. And so I think it's an especially honor to be back again. I'm going to cover, and this is the easiest part of my job, is to cover COG and NANT studies in 35 minutes. So I'm going to be talking a little fast, so just please pardon me for that. What I will be covering today in my talk is update. I had given some early data from this trial, which uses chemotherapy and chimeric antibody for the relapse patients. So we just completed the trial, so you will see an updated data for this. And then we're going to talk about the concept of the new COG studies based on my trial results, where COG is going for their next trial. I have an update from NANT studies, which uses dinutuximab, the chimeric antibody, as well as knowing that there are some new families in the audience with relatively newly diagnosed children. There's update from where Children's Oncology Group is going for the new patients. So as all of us know, chances for long-term survival for relapse and refractory neuroblastoma are not that great, and effective options of treatment are not that plentiful. And the current standard options of chemotherapy like irinotecan and temozolomide, while well tolerated, has only modest activity. And so novel immunotherapeutic agents and targeted agents are needed to help these children. And this is a cartoon from Dr. Chung's review paper from 2013, where it shows that the GD2, which is a glycolipid antigen, which is present in almost ubiquitously present in all neuroblastoma, it can be easily targeted with an IgG1 chimeric antibody, which has the chimeric, meaning that it has mouse as well as human component to it, and it attaches to the GD2 antigen on the surface, and ultimately delivers its killing by bringing the lymphocytes, the macrophages, and the neutrophils with the help of IL-2 and GM-CSF. So most of the time, the chimeric antibody is given with either GM-CSF, which is much more common in North America, or IL-2, which is more common in Europe, or both, as it was done in the LSU trial in North America. It also works by fixing the complement, another part of the immune system, but there is a minor effect. And again, this is probably the fourth time I'm showing this slide. This is from the seminal paper from LSU, showing these are newly diagnosed patients at the end of their treatment, where they have gone through chemo, transplant, and they have minimal or no disease, when they were given a cassette of immunotherapy, GM-CSF, IL-2, and retinoic acid, and when it was compared to retinoic acid alone, it resulted into almost 20% improvement, leading to FDA approval for the dinutuximab, the chimeric antibody, in March 2015, subsequently led to EMA approval in August 2015 in Europe for this agent for upfront patients. So this is data from upfront patients. And again, at that time, Alice and her colleagues showed that even though the trial was designed for patients with no disease and to prevent relapse, there were some patients, only 25 patients, who actually had some disease, biopsy-proven residual disease. And it did show some activity that almost a third of the patient, as you can see, this goes far out a long time. So these kids were cured with this antibody and their cytokines alone, giving an early idea that maybe this drug can be used in relapsed and refractory patients. And by that time, Sloan and other groups have already shown some data that it actually has activity in relapsed patient. And so what is the rationale of using the chimeric antibody for relapsed and refractory disease? As you can see from the previous slide, there is a small number of patients in Alice's trial which showed some activity. At the same time, Alice ran a trial in pediatric oncology group, again in North America, where she showed some responses in bulk tumor when chimeric 1418 was given alone. Several other groups, including Sloan Kettering and others, have shown with different mouse antibody that this is a good target, and it does show responses when it's given in relapse setting. And there is precedent from other diseases like lymphoma, where chemotherapy and immunotherapy has been combined. Rituximab is the agent for lymphoma. It has shown some response and synergy. And so what we decided to do to actually combine both. So we took the dinutuximab and combined that with the standard cassette of irinotecan and temozolomide. Irinotecan and temozolomide has about 12% activity when given singly in patients who were first relapse or refractory disease. So just to compare apples to apples, when we look at the other data, this were for first relapse patient, and this was an open label randomized phase 2 trial, and patients were randomized to receive either chemotherapy, same chemotherapy with dinutuximab, which is the antibody, or they were selected to receive temsirolimus, which is an mTOR inhibitor, which has also shown some activity in neuroblastoma as single agent. And this was for first relapse or refractory disease. Both measurable and evaluable disease patients were eligible. By that, I mean patients whose disease were detected only on MIBG and they did not have a big masses detected on CT scan. They were allowed, as well as patients who had big masses detected on CT scan plus MIBG disease on bone or bone marrow. Both were allowed. If you only had bone marrow disease, you were not eligible for this trial. Patients could have received MIBG therapy as a part of other trial, but patients had received MIBG therapy for first relapse. Those patients were not eligible. And other organ function criteria were pretty standard for a phase 2 trial. And so this was the design. Patients get randomized up front, receive the cassette of chemotherapy, irinotecan and temozolomide for 5 days, and regimen A receives temsirolimus, which is the mTOR inhibitor, on days 1 and 8 intravenously, and then antibody was given days 2 to 5 on regimen B, and GM-CSF was given from days 6 to 7. As if you remember, GM-CSF is important for recruiting macrophages and neutrophils there to provide the ADCC. And again, when the trial was stopped early, I think I gave some of this data last time, with the 35 patients enrolled, regimen A with 18 patients, they had a response rate of 5.5%. So if you remember from this morning's talk, when the tumor shrank by at least 30% and more, they're called PR. And if they're completely gone, they're called CR. And so 5.5% of the patients on regimen A had responses, which is actually even lower than the normal response rate is about in the order of 10%. On regimen B, on the other hand, which is the chimeric antibody plus chemotherapy, 9 out of 17 patients, 53% of the patients had responses. This is one representative child with a large cervical lymph node disease, and just after 2 cycles on regimen B, the disease was completely gone. 5 patients had disease completely disappeared as measured on CT scan and MIBG scan, as well as bone marrow examination if they had bone marrow disease at diagnosis. And 4 patients has partial response. That means their disease was at least gone, reduced by 30%, and or MIBG sites, number of sites were at least lowered by 50%. And these are some of the characteristics of the 9 responders. So these are 9 out of 17. And as you can see, 5 relapse patients, there were total 10 relapse patients enrolled, and 5 of them responded, about 50%. And 4 out of 7 refractory patients responded. 3 patients out of 10 which has measurable disease, measured on CT scan large masses, they shrunk compared to 6 other patients who only had evaluable disease. Two of the 5 patients who had NMIC amplification responded with a response rate of about 40% of NMIC amplified, which is supposed to be more aggressive form of relapse tumor. 4 out of 6, 4 patients had previously received GD2 antibody, chimeric GD2 antibody as a part of ELYSIS trial, and 4 out of 6, 67% of them also among the responders. So suggesting that even when patient has seen the antibody before, the patient still respond to this therapy. On study, there were total maximum number of cycles were allowed were 17, and there is no magic about 17. 17 comes to 1 year, and so 17 cycles were allowed. And as you can see, the 4 patients went to all 17 cycles. Other patients, even though they were responders, the physicians chose to take the patients off and went on to other interventions. And I get these questions a lot, so I just want to clarify here. Once a patient is responder and beyond 6 cycles where they meet the primary endpoint of the study, a lot of the investigator has taken their patients off and gone on to transplant plus radiation therapy, or transplant and radiation therapy, and LSU kind of immunotherapy approach, and retinoic acid. So patients have done all, and a lot of patients ask, what is the optimal therapy beyond this point if my child responds to this treatment? Unfortunately, we still don't know the answer to that, because there are 3 or 4 different strategies people have taken, and there are very small number of patients in each category, and so I unfortunately cannot answer that question, at least empirically. And again, this shows the progression-free survival for this trial, where you can see that despite having responses, patients continue to respond for a while, and ultimately, again, this actually goes to 2 years here. There are some patients, there are very small number of patients, as you can see here, are in follow-up. So each patient who either progresses or dies, which is an event, you see a steep drop. So, but at the same time, it again is a sobering lesson that even when this drug works, there are events that still continue to occur. This difference, by the way, between the 2 regimens was statistically significant, and regimen B was declared the winner, and trial was stopped early because of these results. Again, this is the overall survival that for both studies, both regimens, sorry. And as you can see, there were no statistical significant difference, and both curves are relatively close. Now, this is some of the toxicity data, because one of the things with the chimeric antibody that gets a lot of people's attention, and some of the concerns with the generalized use of chimeric antibody is the toxicity. And as you can see here, the infectious complications are relatively, they're well tolerated. So these are fever, neutropenia requiring transfusions and things. There were no febrile neutropenia episode, but there were patients who required transfusions. The other complication that was noticeable with this regimen was patients requiring oxygen and hypoxia, including one patient getting intubated. So that remains a concern when a relapsed patient has a lot of thoracic disease in the mediastinum or pleura, and when you are giving agents like chimeric 1418, sometimes does result into hypoxia. And the capillary leak was listed as 0 for grade 3. I think there was a patient that we thought that the site did not code it correctly, and we cannot change that, there might be a patient who actually had a capillary leak leading to hypoxia. And then one other thing that we want to talk about is the peripheral motor neuropathy that has been noticed with this trial. And there are 3 cases now reported, and I'll talk in more detail with this toxicity in a second. And this side effects actually makes it imperative that we have a multidisciplinary team who is taking care of patients who are receiving chimeric antibodies. So you need the oncology team, you need the pain service, you need the child life, because distraction is a big part of treating the pain when patients are having pain as a side effect based on this therapy. You need your pharmacy to helping out in palliative care as well as pediatric intensive care. For a minority of patients, they end up going to ICU for either intubation and oxygen requirement or capillary leak. And we have our own clinical practice guideline for our institution, and each individual institution, they need to have their guidelines based on their institutional setup. And again, based on those results, the trial was closed and reopened again in August of 2016 with just one arm. So this is the cartoon for the trial design when it reopened with only arm B. And the rationale for this is we wanted to enroll a total of 50 patients. One of the criticism of this early results when we closed the trial was that there were only 17 patients. And clearly, even though the difference between the two was really large and it met the primary endpoint for the study and the stopping rule, but the numbers were still lower. And one of the criticisms that I'm sure that came from NICE was that the numbers were only 17. We realized that we also wanted to get a more experience of this toxicity profile and the response rate. And so we opened the trial again with an expanded cohort with a goal of actually trying to enroll total of at least 50 eligible patients on this. And so we were able to do that, and we opened the trial and closed it again in May of 2017. And a total of 71 patients enrolled, including the first stage. And this also includes regimen A patients, but there were 53 eligible patients on regimen B, which is the antibody arm, and 2 did not receive any treatment, with 51 eligible for toxicity evaluation. And so this was the breakup. And as one of the things that happened, as you can see here, there were a lot more patients with measurable disease. And I think this was a phenomena that after the early release of the trial, a lot of the families and their physicians actually were moving on from other trials very quickly. So you only had to receive 4 cycles of multi-agent therapy in order to declare that your child has refractory disease. So at the first opportunity, we noticed that there were a lot more patients with a lot more disease actually came on to the trial, with almost 42, so almost like 80% of the patients with measurable disease. 13 patients have received prior GD2 therapy, again, saying that a lot more patients came before they even relapsed and went to Alice's trial. And MIC status is about quarter of the patient, which is representative for the overall neuroblastoma status. And so last patient was enrolled in May, and then they would complete 6 cycles in September, which they completed the 6th cycle in September 2017. Central review of studies, so that's part of the requirement where scans are being reviewed in one place, a neutral radiation and nuclear medicine doctors. They are in process of reviewing that as we speak, and correlative studies to really understand why which are these 50% of these patients who are actually responding and which are the 50% who are not responding. This is a potentially toxic treatment, and ideally we would like to know ahead of time that what are the biomarker for response for this kind of therapy. And so a lot of correlative studies are in progress. We'll talk about in detail of the exact studies. And response data, even though they are not finalized, we cannot release because there are several patients still receiving study therapy. All I can say for the responses that's representative of the first cohort in a ballpark of what we have seen. And so there are no shockers that we are expecting. The correlative studies that we discussed that we are looking into to understand that which are the patients who are more likely to respond. There is some data from Paul Sandal's group and others that ligand mismatch patients are more likely to respond to immunotherapy. And so we are looking into that. Fc gamma polymorphisms. Also, there is some German data from Dr. Lauder's group and Paul's group that one of the polymorphisms in a Fc gamma receptor is supposed to favor immunotherapy response, and that has been seen in lymphoma for rituximab therapy. So Paul is looking into that. We are also looking at presence of HACA in terms of toxicity correlation as well as for responses. LSU is looking into immune function studies with NK receptors, NKP30 isoforms of the receptors. And Shahab Asgarzadeh, he's looking at the tumor microenvironment. There's a lot of emphasis now on tumor microenvironment and the cells which are present in the tumors. Not only just the tumor cells, but the cells like macrophages and the lymphocytes and the type of lymphocytes which are present, and then the NK cells, what they are doing there and how that relates to patient's response status. So Shahab is looking at that, and there is a gene expression analysis that he has a 5-gene RNA signature in NANT that he has piloted. We are looking into correlating that with the response, as well as Frank Ballis and Ami Desai is looking into circulating GD2 levels, as well as pre and post in patients who respond versus who don't. And our group at Michigan is looking at tumor normal paired exome and transcriptome sequencing to see if there are any particular genomic changes that predisposes patients to respond or not respond. And we are also correlating that with tumor microenvironment. So this data, we are hoping to present some of this data in January ANR, but it's too early for this meeting, unfortunately. I wanted to spend a few more minutes on some of the unusual side effects on this medicine, because these are like some of the frequent questions that we get. There are a lot of patients, when they receive chimeric antibody, the the pain is supposed to stop within hours or right away when infusion is complete. But there are, especially we have seen some teenagers where they will have ongoing neuropathic pain, and they have continued on the Neurontin and some of the other agents that they have been given. And none of those patients have remained in chronic consistent pain. The pain does go away. Sometimes it does last 2 weeks, 3 weeks from the last cycle, but it does not seem to continue. Motor weakness, including transverse myelitis, we'll talk a case report in a second, and neuropathies, including blurry vision, which is actually present in almost 30% of the patients we are seeing. Again, self-limiting, lasting from a few weeks to at the most six to 8 weeks, and all patients have made full recovery, and again tells us that we are still learning the full toxicity profile of this agent. And so this was published earlier this year in Pediatric Blood and Cancer, where 3 reports of transverse myelitis on patients who receive dinutuximab were reported. 2 in the upfront study ran by Ellis, and 1 on therapy, which was similar to my study, even though patient was not on study. All transverse myelitis, where the symptoms were inability to move the lower limbs and losing control of the bladder bowel function, were seen after cycle 2 of dinutuximab. All recovered within 6 weeks to 6 months, and they all received steroid and responded to, and 1 patient received plasmapheresis, where you remove your plasma and certain antibodies and put the plasma back. 1 patient received that, and all patients responded to the treatment, and within 6 months they again had more or less baseline function, neurological functions back. And all patients, the common theme among all the patients we were looking at, because some of them were relapsed, some of them were upfront, all of them had received radiation to the area on the tumor, as most of them, as you know, have abdominal tumors, and some of the radiation field was including the spinal area. And since all of the patients had cycle 2 as their initiating event, the authors and we hypothesized that that is related to some allo antibody production after the exposure during the first cycle. When they again get challenged with the same foreign protein, they seem to develop this specific side effect in setting of having radiation or some of the other factors that we still don't understand. There were some other scary events also reported, and then I get a lot of questions from parents and physicians alike. There were 2 cases of sudden death reported on patients who were treated with dinutuximab. They were both in older kids. 1 was 12, 1 was 14. 1 was after cycle 2 in osteosarcoma, and 1 was after cycle 14, where the patient was in complete remission on the dinutuximab, and that was on my study. Both patients actually had autopsies done, and including full brain autopsies and cardiac and others. And we evaluated both patients' previous cardiac function because they have received anthracycline therapy, which can affect their hearts, including their rhythm strip, and looking at the QTc interval. All of them was negative. And so at this point, for those 2 sudden death in older kids, we do not have any clear understanding of why. But people should know that there is a potential concern, and this is not a completely benign agent. Again, so I think with this trial coming to an end and we are waiting for the correlative data to come out, the real question is, so where are you going from here? So where is COG going from here? I'm not going to talk about the humanized 3F8 data that Dr. Chung will talk about, and Dr. Furman will talk about the St. Jude experience for the humanized antibody of their version, as well as their new patient data. So I would primarily focus on talking about some of the strategies that COG looking into, that can we improve the efficiency of the irinotecan, temozolomide, and dinutuximab by combining additional agents like DMFO, and can more than 53% of the patients can respond, or their toxicity can be lowered by using DFMO, or agents like lenalidomide. Or can this combination be used in induction therapy? And again, as I said, I think COG pilot is in the process of being written for trying chemotherapy plus chimeric antibody in a limited setting institution, but I do not have any data. No patient has ever been treated on that. Can we also combine these agents, dinutuximab, with other agents? So instead of using GM-CSF and IL-2 for consolidation of front patients, can we use a cassette of IT and dinutuximab in consolidation and compare it with the controlled setting and see whether this is actually even better than the upfront setting? So the one trial that is going to shortly open in the next few months is adding DFMO to the irinotecan, temozolomide, and dinutuximab. This is the next relapse trial, which is going to follow my trial. Probably won't open till spring next year. And DFMO is an irreversible inhibitor of ODC1, which is an enzyme, ornithine decarboxylase, which is important in polyamine synthesis. And this is much more important in patients who have NMIC amplified tumors. If you have more NMIC amplified tumor, you have higher expression of ODC1 and then higher polyamine synthesis. And polyamine synthesis really actually drives tumor immune milieu, and it actually plays important in causing tumor immunosuppression in patients and suppresses some of the cytotoxic T cells and NK cells effect, as well as it actually impacts how painful chimeric antibodies would be, or any chemotherapy would be in a patient who is receiving agent that can cause pain. And so the rationale for using DFMO is by adding DFMO to the current cassette, can it increase the response rate and can it reduce the pain that patients are experiencing? And there are several single agent DFMO data available where they have been combined as a single agent for the NTRK NMTRC study, pediatric phase 1 trial with DFMO with VP16, and NANT DFMO with topocytoxin and Celebrex trial. They're all single arm studies, and there is no randomized data showing DFMO provides any benefit in relapsed neuroblastoma patients so far. Some of the side effects of DFMO can overlap with some of the agents that we are using. So a word of caution: diarrhea. Irinotecan can also cause diarrhea, as well as temozolomide and vomiting. So the toxicity can be additive, causes hearing issues and tinnitus, as well as some reports of seizures with high doses. And so this is again an agent that we will be carefully watching in terms of toxicity. And so the specific hypothesis for this study is addition of this agent, can it improve the response rate, and can the side effect of the regimen would be better. And we will also compare that the response to DFMO, is it related to the patient's NMIC status or status of the ODC gene copy number. And we will be looking for some urine and plasma biomarker in terms of synthesis of polyamine levels. And this is the trial design, which is very similar to my trial, where you can see the first regimen A would be the trial that we earlier talked about, which was published in Lancet Oncology, and that would be the standard arm. And addition of DFMO would be the experimental arm, and they would have scan after 2 cycles. And if they have disease which is stable or better, they will continue for a total of 17 cycles. If they have progressive disease, they come off the chemotherapy. And this is again showing the chemotherapy cassette, where regimen A is the standard treatment, regimen B, where the first cycle they get 6 days of DFMO alone to understand their toxicity, and then subsequent cycles they get continuous oral DFMO and the other standard cassette. Again, similarly, NANT group of a neuroblastoma, new novel therapies in neuroblastoma, a group is also looking into adding other agents, other immunomodulatory agents like lenalidomide with chimeric antibodies to see whether that adds to the responses, and does that make the side effects more tolerable in a refractory setting. So why lenalidomide? Lenalidomide is a thalidomide analog, but it's less neurotoxic and causes less sedation. And it has multiple anti-cancer mechanisms, including reducing the blood vessel formation, downregulation of TNF-alpha in an inflammatory state, inhibition of COX-2, as well as the activation of the T cells as well as the NK cells. And the efficacy of lenalidomide has been shown in multiple myelomas, CLL, non-Hodgkin's lymphoma, and MDS, and has been FDA approved in United States for myelodysplastic syndrome. And lenalidomide has some specific activity against neuroblastoma, including activating the NK cells, as well as reversing the suppression of NK cells by TGF-beta, as well as IL-6 secreted by the tumor and tumor macrophages. It also inhibits the pure pro-tumor function of tumor-associated macrophages. And lenalidomide was shown to significantly increase the anti-tumor activity of the NK cells, especially when it was combined with chimeric 1418 antibody in a mouse model, and hence the combination and the hoping for some synergy. And so the study design is that patients would be receiving lenalidomide orally for 3 weeks out of 4. Chimeric 1418 is given on days 8 to 11 for 4 days, and cisretinoic acid, the Accutane, is given for the last 2 weeks. And 5 dose levels were decided, and they were all completed, and patients were enrolled on all 5 dose level. And total of 27 patients were treated on this trial, and 20 were evaluable for response. And what it showed that the regimen was very nicely tolerated, very little hematological toxicity. The usual dinutuximab toxicity were seen, absence of serious complications, especially no serious capillary leak or hypotension or high-grade fever. And response are, again, we are waiting for the final statistical analysis of the 20 evaluable patients, but all the correlative data were complete, including data showing that when this regimen was given, there was a significant activation of NK cells, and the effector NK cell subunit went up as the regimen was given, including it went down first when the chimeric 1418 was given, but ultimately going up. And this is into the showing the effector NK cells. And it also shows the antibody-dependent cellular cytotoxicity and deruxcytotoxicity in the chimeric arm compared to the control arm. More cells dying in vivo. So we are hoping that this biological correlates and positive biological correlates results into better responses. Again, it will not be comparing, just to make sure that people understand, this was for multiply refractory patients. So patients who went on to the studies were not first relapse patients. So it would not be comparable to my trial results. This would be a highly refractory patient population. And there is some early signal. Unfortunately, we cannot talk about the responses because of some of the stipulations from the CTEP, but it definitely shows a positive signal in terms of clinical activity. And again, so this was my talk for the relapsed patient and relapse strategy from the COG and NANT. Last 5 minutes I want to spend on the strategy that Children's Oncology Group has for newly diagnosed patients. And so we're going to talk about the COG ANBL 1531, which is a phase 3 randomized trial where patients get randomized and randomly assigned to different treatment strategies for newly diagnosed high-risk neuroblastoma patients. And slides thanks to my friend Ro and Steve from Philadelphia and Boston. So this is, since most of the people in crowd are familiar with different induction regimen and rapid COJAK, just want to point out this induction cassette for Children's Oncology Group, where they get 5 chemocycles. First 2 are similar, topotecan and Cytoxan IV. Then there is a stem cell harvest. Third cycle includes cisplatin and VP16, followed by vincristine, adriamycin, and Cytoxan. Fourth cycle, surgery, and cisplatin and VP16. This 5 surgery and the 5 chemocycles makes the induction cassette for the North American Children's Oncology Group. And then there is evaluation. So when Julie Park ran the last high-risk study, ANBL 0532, one of the randomized questions for that trial was whether a single transplant done with carboplatin, etoposide, malphilan is better, or 2 transplants done with 2 different preparative regimen is better for high-risk neuroblastoma. And what the study found, the tandem transplant patients, high-risk neuroblastoma patients who received that cassette that we talked about, followed by 2 transplant, had significantly better outcome, 61% over 48%, with a significant p-value. And that benefit carried over for patients who actually went on to receive immunotherapy afterwards. Their benefit continued and was significant, where 73% of those patients, these are 3-year response rate, sorry, I didn't put it there. It's a 3-year event-free survival of 73% to 56%. And so showing that 2 transplants are better than 1 transplant. So going forward for this trial that we're going to talk about, everyone will be receiving, except for minor subset, will be receiving to transplant. So how to improve on those results? So there are two strategies the Children's Oncology Group is taking. They are introducing ALK-directed therapy for newly diagnosed patients. We heard this morning the talk about ALK and first, second, and third generation ALK inhibitors for relapsed, and we are taking some of the data from Yael Moses' lab and John Maris's lab to include ALK inhibitor for about 10 to 11% of those patients who either have ALK mutations or ALK amplification. They will be given chemotherapy plus ALK inhibitor up front. So when a patient gets diagnosed, the tumor samples will be sent and results will be available within 3 weeks of the time the material will be sent. So that would be one strategy. And the second strategy is to use radiolabel MIBG therapy. This is targeted radiation to neuroblastoma cells. This has shown to be effective strategy for many relapsed patients, and the best response rate has been reported are anywhere from 20 to 36% based on the patient population treated. And so Children's Oncology Group is going to introduce MIBG in upfront newly diagnosed patients and not waiting for them to relapse to try this agent. And they are going for FDA approval for MIBG, which currently is not approved in any country. And so it's a registration trial for MIBG. And so they're going to have 2 interventions in this large stage 3 trials. And again, so the aims for ANBL 1531 is to determine whether the incorporation of radiolabel MIBG improved the event-free survival with acceptable long-term toxicity, and incorporation of crizotinib, which is the first generation ALK inhibitor, into patients with ALK aberrations. Does that improve the outcome? And they're going to study the toxicity profile and event-free survival for those population. And this is this rather simple design here for this trial. So just so everybody understand this complicated slide. So this is the 11% of the patients who have ALK aberrations. They would directly go onto this and they receive the five cycles of chemotherapy, surgery, as well as the 2 transplant, as we discussed, followed by radiation, and then they will go to the new consolidation therapy. There will be about 11% to 12% of patients who do not have MIBG uptake at diagnosis, which we call MIBG non-avid patients. Those patients will not receive the randomization for MIBG, and they will receive the standard therapy as done in the previous cycle. And so the rest of the about 77 to 80% of the patients would be randomized to receive the standard cassette with 2 transplant versus 4 cycle of chemo, MIBG, 5th cycle, and 3 cycles of chemo, MIBG, 4th and 5th cycle, and 2 transplant. And addition of MIBG, does that add? And they are also studying in this arm what is the toxicity profile, and having MIBG therapy with a transplant preparative regimen called BlueMel, which is very much the standard in European centers, busulfan and melphalan, compared to CEM, which is more of a standard in North America. What is the difference in toxicity as well as the response rates? And so this was for the induction as well as the consolidation. So what are the new strategies Children's Oncology Group is using for the newly diagnosed patients? And so we know this slide, this is what Alice has done, and this is the standard of care. So can you improve upon that? So the new concept is actually testing whether that standard of care of chimeric antibody, retinoic acid, GM-CSF, and IL-2, can you compare it to chimeric 1418, irinotecan, temozolomide, and GM-CSF? In other words, my relapse trial cassette. And can that improve the survival? So it will be a randomized trial at the end after patients who have received transplant and radiation. And they will be randomized 1-to-1 to see which one is better in terms of less patients relapsing. Remember, these are newly diagnosed patients. And I think I have my 2-minute warning. So just a concluding slide here. The dinutuximab is an active agent in newly diagnosed as well as relapsed and first refractory neuroblastoma patients. The important work is ongoing where correlative studies are being done to really identify the biomarkers to suggest the response to this chemoimmunotherapy. And new chemo as well as immunomodulatory agents are being added to see if they can improve upon the response rate already seen with this chimeric antibody, or if they can reduce their side effects. and COG is in a planning stages for testing dinutuximab and chemotherapy in newly diagnosed high-risk neuroblastoma patients. Again, my thanks to many of my CO Children's Oncology Group collaborators, my trial partners and study team, COG institution, NANT staff, and most importantly, patients and families. And I think with that, I end here on time. Thank you.